when patient is dizzy, this could be because he's going to pass out. Okay, a sense of disequilibrium. Patients may also, when dizzy, may say, "I'm in imbalance." Okay, or true spinning vertigo. Okay, so there are different description of the complaints. In vertigo, spinning vertigo, disequilibrium, and syncope, all these patients would say, "I'm dizzy." Okay. Well, numbness. Numbness may mean a complete loss of feeling, so you cannot feel anything. Numbness. A positive sensation such as tingling or even weakness. So some patients would say, with weakness and tingling, and of complete loss of feeling, some patients would say, I feel numb, or I have numbness. Okay. Blurry vision may be used to describe unilateral visual loss, as in transient monocular blindness or diplopia. So when patient has this diplopia, transient monocular visual loss, patients may also describe it as blurred vision. Okay. The interpretation of the true meaning of the words used by patients to describe symptoms obviously becomes even more complex when there are differences in primary languages and cultures. Of course, that's understood. Let's go to corroboration of the history by others. It is almost always helpful to obtain additional information from family, friends, or other observers to corroborate or expand the patient's description. Memory loss, aphasia, loss of insight, intoxication, and other factors may impair the patient's capacity to communicate normally with the examiner or prevent openness about factors that have contributed to the illness. Okay, when patients have memory loss, of course, they cannot remember, right? When they have aphasia, they cannot speak. A loss of insight, of course, they could not say anything about their diseases. And then when they are intoxicated, well, of course, they cannot communicate properly. So other people's of information could help. Episodes of lack of consciousness necessitate that details be sought from observers to ascertain precisely what has happened during the event. Obviously, you need to rely to other people on this. Number 4, family history. Many neuro disorders have an underlying genetic component, obviously. The presence of a Mendelian disorder, such as Huntington's disease or Charcot-Marie-Tooth neuropathy, is often obvious if family data are available. More detailed questions about family history are often necessary in polygenic disorders. Okay, so what are the polygenic disorders? Such as MS, migraine, and many types of epilepsy. Okay, it is important to elicit family history about illnesses in addition to neurologic and psychiatric disorders, of course, because it may contribute to that disorder, to the neuro disorders present. Okay, a familial propensity to hypertension or heart disease is relevant in patient who presents with a stroke. Obviously, it is more likely that it would be a stroke if there is a strong family history. There are numerous inherited neurologic diseases that are associated with multisystem manifestations that may provide clues to the correct diagnosis. So, what is that? Neurofibromatosis, Wilson's disease, and mitochondrial disorders. Okay, so that is about the family history. What about medical illnesses? Number 5. Many neurologic diseases occur in the context of systemic disorders. Okay, so what is that? Like diabetes mellitus, hypertension, and abnormalities of blood lipids predisposed to cerebrovascular disease. Of course, when you have DM, hypertension, and dyslipidemia, there's a big chance you could have a stroke later on. A solitary mass lesion of the brain may be an abscess in a patient with valvular heart disease. Yeah, because there would be an emboli which could be thrown into the brain, and it can cause, which is full of bacteria and can cause an abscess in the brain, of course. A primary hemorrhage in a patient with a coagulopathy. Obviously, when one is known to have a hypercoagulable state or bleeding disorders, bleeding factors deficiency, then primary hemorrhage could be considered. A lymphoma or toxoplasmosis in a patient with AIDS. AIDS, acquired immunodeficiency syndrome. HIV positive patients could later have toxoplasmosis in the brain or lymphoma, because this is a disease of the immune system. Toxoplasmosis is a disease of a parasitism, okay? Or a metastasis in a patient with underlying cancer. Okay, when it says the patient has cancer and there are focal neurologic deficits, okay, it could be due to a metastatic process. Okay. Patients with malignancy may also present with neurologic paraneoplastic syndrome or chemotherapy or radiotherapy. Okay, so this neurologic paraneoplastic syndrome, it's like neoplasm also, but it is not. And sometimes it's complications of chemo or radiotherapy. Marfan Syndrome and related collagen disorders predispose to dissection of the cranial arteries. So if there is dissection of cranial arteries, there is rupture of cranial arteries, it could be attributed to a predisposing previously present disease of Marfan Syndrome and related collagen disorders. And aneurysmal subarachnoid hemorrhage. It speaks the same, right? Okay. Aneurysmal SEH or subarachnoid hemorrhage. The latter may also occur with polycystic kidney disease. So if you have polycystic kidney disease, then you could have an SAH. Don't forget. PKD is related to SAH. Various neurologic disorders occur with dysthroid states.